glad to be here and share some of the concept that I have used in my practice for user endoscopic DCR for revising the failed case. So the content today I will include about the how to evaluate the bone adequacy, and the second part about the how to evaluate and perform the well flap approximation in the failed DCR. If you are the beginner, you would know the normal lacrimal anatomy, and the right hand side is the ideal the ostium flap that should be open widely. So the difference finding that I have found between the failed endoscopic DCR and the external DCR, the couple issues that have some difference. And the classification of the failed DCR I divide to be two parts. The first left hand side is the fail from the endoscopic DCR, and the right hand side is a fail from the external DCR. So if you take a look on the first video, you can see the external approach for the external DCR. The surgeon can approach by transcutaneous, and the bone could be removed. But one thing that has some difference is the bone underneath the medial canthal ligament could not be removed by the external DCR efficiently because they have blocked by the medial canthal ligament. And the second one is if you approach by the endoscopic approach, the benefit if you can go to the tranasally and you can remove the bone on the lower 2/3 and upper 1/3. But one thing that we need to be very careful is not to do so much. Sometimes you may disturb the medial canthal ligament. Next, how to evaluate the adequacy of the bone. I use the 45-degree test, and we can divide into two parts. The first part is 45 degree up, and the second is 45 degree down. Let's see from the 0 to 45 degree. Before that, the 45 degree test is a quick test. If you understanding the concept, you can use this one in 2 seconds to evaluate the adequacy, and can you use this one for apply for the future plan for the surgery. For prepare the bony ostium, this is show the 0 degree, you apply the tip of the Bowman probe. The pink area show the expected bone that should be removed. And if you try to do the 45 degree up test, you just bend the proximal part of the Bowman probe down and apply gently, superiorly. And if you can put the tip of the Bowman probe pass to the middle part of the lacrimal sac, and pass through the area of the root bone and touch to the septal mucosa. That means the 45 degree up is positive. And this shows that you can remove the upper 1/3 of the frontal prostate of the maxillary bone efficiently. But sometimes in my practice, I have found that in the beginning part of my practice, I did not remove the upper 1/3. So 5%, 7% could be fail from this point because of the scar tissue encroaching. And I could show you later. And this video show after removal of a good piece of the bone on our upper 1/3. You can do in 2 seconds by 0 and 45 degree and show the adequacy of the bone. The next one is very helpful for the 45 degree down test. This one used for evaluating the lower 2/3 of the frontal prostate of the maxillary bone. And this one very practical for the evaluate the degree of the scar tissue in revision for the lip fail case. And I will show the 45 degree down. This is on the left hand side it show the positive, and the right hand side it show negative. And the 45 degree down test is this is show the negative. And so the soft negative. The soft negative is mean when you put the tip of the Bowman probe down, you can not pass through the nasal cavity freely, so it stops. You can feel the feeling of the soft. That's called soft negative. And the one is called hard negative. The hard negative is mean you try to do the side linking. The very practical will be applied from the upper or lower punctum, and the tip of the Bowman probe and the tip of the side linking could not be passed. It's stuck hardly. So we can feeling in the tip of the Bowman probe that is very hard, and the endoscopic view is show nothing, show no movement. That's called the hard negative for the 45-degree down test. And this is represent that the previous surgeon may did a lot of scar tissue, and you're gonna be remove the scar tissue and sometimes of the bone. That's prepare for the thinking about the surgical plan. For the volume study, for the average case that I try to correct some patient by 200 cases, we found that the average appropriate volume is about 0.3 cc. So the next is FAB concept. The FAB concept for the revision DCR, they have two parts. The fail from the endoscopic DCR and fail from the external DCR. And this one show that the previous surgeon did not remove the upper 1/3 properly and disturb them too much for the nasal mucosa. So when the remove only the lower 2/3 and stop. So the mechanism is if you do that, and when they have something like the scarlactite and scarlagmite phenomenon, the scar tissue start encroaching gradually, and when you put the cone stent, it's okay. But when you remove the stent, it initiates the SUM syndrome. Why? But sometimes the contraction more, so the total obstruction happen. This is show the revision of the SUM syndrome. If you do the 45 down, and it's called soft negative. We can apply very simple by cut the vertical cut and initiate anterior or the posterior flap, and then rotate the posterior flap posteriorly or anteriorly, and do the only one simple suturing of the flap inside the node. This can be achieved and very easy can do by the inside the office. And the second one is a fail from the external DCR. This one is more challenging because the previous surgeon may disturb too much, and when you observe, the scar tissue would be a lot more on the medial part of the lacrimal sac, because when you approach from the trans skin, sometimes you approach, the previous surgeon did not do the good approximation, and the bone could not be removed underneath the medial canthal ligament. So that's why it's called the fail from the external DCR. And what we found, the mechanism is when we put the stent out, the total obstruction happen, and then we can see that this is show the part of the bone, and to approach, we need to evaluate the bone and remove the upper 1/3 of the bone properly. And for the scar tissue, to manage with the scar tissue in this condition, we need to do the surgery, and this is show a very thick scar tissue inside the nose and a tiny nasal ostium. And when we in this case, we found it's 45-degree down hard negative. So keep in mind for the surgeon intraoperative, we have to fight a lot in this condition. We have to do the vertical incision, remove the very thick scar tissue underneath the nasal mucosa, and sometimes we need to remove the thick bone. And what we found in this condition, in the medial aspect of the lacrimal sac, we found a lot of scar tissue. If we approach this one with the conventional endoscopic DCR, I'm pretty sure in this condition, they're gonna have the high % of the fail after this one. So we think about why don't we suturing the flap inside the node with two suturing. This one can do thoughtful try to make the approximation of the lacrimal mucosa and the nasal mucosa forcefully. And if you can open that, you do everything. You put the silicone stent, you put the gel foam, you put the Kennicott, or sometimes put the MMC. And lastly, if you have the thick scar at the common canaliculi, this is more challenging. This is going to happen after multiple external DCR or multiple endoscopic DCR revision. In my life, I have seen like 5 times, 6 times for the revision. This is a good video that show in the case that have the very, very thick scar in the medial aspect of the lacrimal sac. When you found this one, they have a lot of scar inside the nasal mucosa, medial wall and lateral wall of the lacrimal mucosa. including the common canaliculi. When we approach to this one, it's going to be very difficult. We need to evaluate about the bone. We need to remove residual inadequate bone. This you can see this is a very thick part of the upper 1/3 of the frontal fossa of the maxillary bone. Not finished yet. When we cut in the approach to the scar tissue and remove the thick scar tissue, at the common canaliculus they have the very thick scar, sometimes 3 or 4 millimeter. In this case, I think about we can try to make the horizontal incision and make the scar tissue and try to think about the imitate the superior flap. Using the scar tissue imitate like the superior flap. And in this case, we apply the superior flap suturing because we want to fight with the cavity. If we don't do some flap suturing, in this case, they have high percent that after surgery, the superior flap or scar tissue will flap down like by the cavity. So in this condition, we overcome with the flap suturing and then lyse a lot of scar tissue and put the thick side of the silicone tube and then inject the steroid, and after the surgery multiple every couple weeks follow up weekly. If you found the granulation tissue post-operatively, we remove the scar tissue or inject the Kenacort periodically. That could be the good practical way to overcome the difficult fail case. That's my thought. Thank you very much. Thank you.